Hello and welcome back to the Fools
Seldom
Differ.
podcast.
Today we're speaking about
Nursing
study,
and what to do after your study
emergency nursing,
and the nursing culture.
and then after all of that, what grinds our gears, because we forgot to do that last week.
We did.
And that really grinded my gears, I can tell you. But let's jump right into the nursing,
Sounds good.
shall we?
Yeah,
So, 3-year degree.
it was.
By the way, Lily is obviously a nurse, as you can see how
I'm in
she's
my
dressed.
fun scrubs for those. I thought I'd put them on for
It's
the
not
show.
cosplay.
No. I do wear this to work every Friday. Maybe not this exact one, but some sort of fun scrub.
And that's why we're speaking about nursing, I guess. Lily's very passionate about nursing because she is a registered nurse. We didn't get this topic out of thin air. It has purpose.
It does. And I've been a registered nurse since June now. So, well, June
2023.
Yes. Should speculate that. It's a 3-year degree, technically. I did it in 2.5 years.
Why?
Because
Because I'm smart.
Well, I just rigged the system a little bit. They weren't too happy about it, but there was a couple things that were in like sessions rather than semesters, so I could get away with doing 3 in a session and 2 in a semester in the same half of the year, which is 5 subjects, which normally you only do 4 in a half a year. So, yeah, I did that, and I did my internship earlier than what I was meant to because it was the last thing I had to do.
Do many people do that, or are you like a one-off enigma?
Yeah, I don't think anyone has done it, and that's why they were kind of like, well, no, like it's not possible. And I was like, well, what? So I'm just going to sit here for 6 months until I can go on my internship and do nothing for 6 months, or I can go on my internship in a month and be done. And yeah, they were kind of like, oh, well, if there's a spot, then sure, you can go, but we can't guarantee it. And I said, well, you know, like that year that I had done it, over half of the cohort across the whole campuses had failed one of the assessments, so they couldn't continue until the following year. So I was like, well, I'm pretty sure there's going to be a spot because like half of the grade failed. So I did it. And here I am.
Did you enjoy it?
I did. There was a lot of hard times and a lot of stress.
A lot of proofreading?
Yes, Andrew did a lot of proofreading for me, which was I'm very grateful for that because I often overlook and skip over things pretty quickly when I'm proofreading. So it was very good.
Yeah, a big part of when studying, and side note, when you're writing essays, everybody, or anything you're writing, an editorial, an opinion, anything, read it out loud back to yourself. Don't read it in your head, because you read it out loud, the amount of times you go, oh, God, this sounds terrible. I need new words. I need to structure this sentence differently. So, side note that was. But
yes, he definitely taught me that because I just would read them in my head and go, oh, that'll do. And then
you read it and you go, oh, it doesn't make any sense.
The teacher often would, like, at the start of the degree say, oh, are you sure this is what you wanted to write? I'd be like, oh, whoops. So that's when he started proofreading everything.
What was something you didn't enjoy about it?
Well, the placements are hard, and there's you're working 5 days a week, which is normal for like normal office jobs and things like that. And obviously farming 7 days a week. But most nurses in the hospital or anywhere are working usually 7 days a fortnight. We were working 10 a fortnight. So we call them points in the hospital. So like I work 0.7 now, which is 7 days a fortnight. And so you'd say 1 or full time is 5 days a week. And we were doing that as students, not being paid, having to travel, up to an hour away to get to placements and everything. And that was really taxing on your body because you also, you weren't able to make money because you couldn't really work around placements as well. So it was tough. It was.
Yeah. Do you want to speak about unpaid placement?
Yeah. I mean, well, what do you think about it?
Depends, because were your expenses paid?
Nope.
No. So your travel wasn't paid, your food wasn't paid?
Nope.
Your rent wasn't paid?
Nope.
that's something which I would certainly encourage the government to look into.
Mm,
I can, the point of an internship is that you're not there to get paid.
mm,
You're there to learn.
mm,
And so perhaps I'm not totally on board with paying interns to be on the job, but to get there, travel, and to exist, so rent and feed, um, food, I should say, not feed like the cattle, but that should probably be paid for,
mm,
genuinely.
mm,
It's something that the government should certainly look at,
mm,
because that will probably entice more people into nursing,
mm,
which we know in the next 5-10 years, you've got an aging demographic in the nursing, what would you call it, in nursing,
mm,
and that's really dangerous because it's going to be a really lacking workforce
mm,
soon, and they need to be more enticing to newer,
mm,
younger people who are enthusiastic, who will go, "Oh, that's encouraging that the government will pay for that for me to do this. So
mm.
I'll give it a shot."
There is a positive that thing that the government's doing is they have made the TAFE course free at the
For
moment.
enrolled nurse.
Yes, so
Really?
it's not
Free?
yep. It's not a registered nurse, but it's the next one
Since when?
down. Since mid last year.
Yeah, right.
Mm, yes,
That's not bad.
it is. It's pretty good.
Mm.
The registered nurse degree is subsidized slightly, so it's like cheaper than doing a business degree or something like that. But it's still like you still have to pay for it, obviously, but it's nowhere near as expensive as a business degree or anything. Um,
Do many people you studied with drop out? Or do they use it as a stepping stone to get into something else when you're studying nursing? Did you find that?
I had a few of them that didn't get into midwifery, and because it's a higher OP to get into midwifery. So they went and did nursing for like the first year or two and made sure that they had like distinctions and high distinctions and then transferred across. But most of them stayed through. A lot of them like considered dropping out after. So they changed the way that the practical video assessments were marked. So when I went through, it was pass or fail. That was it. If you got one thing wrong in the list, automatic fail. But now it's 50%. But there's a few extra things they have to do, like questions and things like that they have to answer. And if they answer them right, they get a point, whatever. But yeah, that was what I was saying about the whole 50% of the grade had failed. It was in those practical ones, which fair enough. Like that's the stuff that you're going to be doing on the job every day. And if you can't get it right, then probably shouldn't be doing it because it's literally what you'll do every single day. But it is also very hard to do it in front of a camera. Like watching my videos back, I'm like, oh God, is that really what the teacher had to mark me on? Because that was shocking. Like now I just do it no ease every single day. I do like I'm handing medications out, all that sort of stuff. But a lot of people considered dropping out after they failed. And some people had actually failed that subject twice until they brought this new aspect in. It was rough.
Would you say it's a difficult course? Or is it a fairly, like, in comparison to others? Or is it just it has a difficulty to it, element, but it's not like the hardest course in the world? Like, what was your measurement of it?
I don't think it's the hardest course in the world, but if you're not passionate about it, it is difficult.
Mm.
Like there was quite a
That's
few.
everything, though.
Yeah, exactly. There was a lot of girls and guys that I think were interested in doing it, but they weren't super keen. So they weren't, getting the best grades that they could because they didn't really want to know all of the knowledge that they could have found with the degree. And like, yes, the degree doesn't give you every single piece of knowledge. I'm still learning everything new now. Like there's things today that I was like, from work that I'm like, oh, what is that? Today we learn something new, especially when you're, not even a year out yet. Yeah.
Yeah, I mean, I didn't study anything to be a dairy farmer, but in my life, constantly learn new things. And I think many people listening to this or watching this can relate to that. In whatever they're doing, we are constantly learning new things, which sometimes they're qualifications which we need, and sometimes they're useless information, but
Yeah,
we learn it.
this is true.
And it might come in handy one day, but it may not.
No.
Yeah.
Yes. But yeah, I mean, I enjoyed everything that happened. I, went out west to do a placement for 4 weeks as well. It was like 8-hour drive from where we live, and stayed there for 4 whole
Did you
weeks.
enjoy that?
I did. I mean, it was a lot because obviously, like, I was paying for my food, I was paying accommodation and the travel to get out there, and then not being paid to go on placement. But it was very interesting. It was a very small hospital. There was only 4 emergency beds. That one included a resus, so really only 3 beds, and like 2 consulting rooms. And it was cool. Like,
So it was like a public system GP clinic,
yeah, kinda,
kind of.
kinda.
Yeah.
I mean, well, yes and no.
Not very big.
No, but
In fact, I know of GP clinics that are bigger than that.
yeah, the town wasn't that big though. It was, near a mining town, so it was fairly big, and lots of accidents did happen. Like, I got to see some cool, like, degloving from stuff, and like in the mines, like where they'd hit their hands up against metal and stuff, and it was pretty cool. And I got to help reposition a fractured tib fib. It was completely fractured through, and like they were next to each other.
Yeah,
rather
let's not
than
get
in
ahead of ourselves because we've got structure to this podcast.
We do, true.
Lily's getting lost she's just getting lost in it, mate. She's so passionate about it. The things she tells me, pillow talk. Oh. So, after study, once you're
Yes.
done at university, we've got grad years, and after that, you're not guaranteed a job.
Mm.
So, what's a grad year to begin with?
So
It's a year of guaranteed work,
mhm.
but then after that, you're not guaranteed anything. So it's basically you're on probation the whole time,
Pretty much.
and you have to be appealing to the people you are working with, or what?
Yeah.
Or you add it to your resume and say, I worked here for a year. Can I work at your hospital now?
Yeah, that too. So when you're studying, all you'll hear during your degree is, oh, make sure you apply for your grad year. Don't forget to put that on your resume so that they can see it for your grad year. They make it out that a grad year is the only way that you can be in the public system as a nurse. But it's not true at all. I didn't even apply for a grad year. The grad year is basically like you're still studying when you do the grad year. You have to do assignments or like presentations while you do 0.6 to 0.7, so 6 shifts fortnight or 8 shifts fortnight of work, as well as putting on a presentation and assignments for a whole year. And that's in the public system. And you're not guaranteed a job. So one of my friends, there was 8 grad years in her ward, and 3 of them got offered a job at the end of that year.
So 5 of them had to go elsewhere, private or GP clinic or other public hospital to find work.
Yeah, they found out 3 weeks before the end of their grad year.
Great. So that's not very much time to
try and find a new job.
That's terrible.
Yeah, it's a bit rough.
And it's common practice.
Yeah, it happens all the time. It must
happen each year.
Every year. Usually, the hospital that I work at, last year they only got 3 or 4 grads, and I think only 1 or 2 of them got jobs after in the whole hospital. Whereas like the bigger hospitals get a lot more grads, but then they also have a lot less jobs that they offer at the end of it.
So after study, GP clinics versus private versus public.
Yeah, there's a lot of aspects that you can go. You can go to aged care as well. Yeah, I didn't apply for a grad at all because I was just like, oh, I had a job offer already before I'd even finished to work at a GP. So I was like, well, I'm just going to take that and see what happens because I'd rather let someone who doesn't have a job have the grad year if I can. and I stayed there for 3 months, and I applied on like Smart Jobs, the government website, for a public hospital, just expecting to get casual. So I was just going to work like, one Saturday or Sunday a month, and I got offered a position in emergency, which is where I am now. Yeah, it was crazy.
Do you want to speak about emergency nursing?
Yeah,
I can speak
absolutely.
about that to an extent.
Yeah.
So with Mum,
Mm.
my mum suffered. Who wants a long story? Mum suffered a subarachnoid hemorrhage back in 2017. She had a subsequent stroke, 2 strokes rather, caused by a vasospasm. These were the initial brain injuries my mum sustained. She went to the local emergency, and then she was airlifted to the capital city, to a big hospital, where she was placed in emergency there as well. I think. I don't really know. After that, I wasn't a part of it anymore. I was on the farm, keeping everything afloat while everyone was with Mum. Mum is, of course, at home now. But yeah, that was crazy. The work that they did to stabilize her, to keep her alive, would have been full on. Because brain injuries, I don't know how often they really come through.
Not very often.
No, it's insane.
Especially at like the local hospital. It's I don't think I've seen one in the time that I've been there, which technically I've been in emergency since July 2022, because I was a USIN beforehand.
Which is a university student nurse.
So we get paid to work at the hospital while still being a student nurse.
Not bad. That's not bad.
But they don't pay us for placements.
Yeah, that's not good.
No.
You have to get in there and fix it.
I know.
Yeah.
Somehow.
So emergency, why did you choose emergency? What appealed to you about blood and guts and people sticking things up where they're not meant to and getting their hands stuck in things and or doing naughty things to other people? What about that appealed to you?
Well, from being on the wards and do it like it's the same thing every day basically on the wards. Whereas,
so you don't like routine, you like disorganisation?
I don't not like routine. I do like routine.
To an extent.
To an extent. But I love...
He likes routine sometimes.
Yeah. I like... my brain loves to be challenged and to be doing lots of different things at once.
Constantly challenged.
Yeah.
She lives in a state of challenge.
Whatever.
But so I'm guessing you've gone for emergency because it's different each and every day.
Yeah.
Whereas the wards they are different, but only to an extent, and there's a lot more routine involved.
Yeah, and the wards at our hospital too are very much, it's more so an aged care home than actual ward nursing, because it's just like gen med. It's not a specialist ward like a urology ward or a gynae ward or anything like that. It's purely anything and everything, but mostly it's just the elderly, because the younger people usually get shafted to down the road to one of the other hospitals, because like they are fine to travel, whereas all the oldies are like, no, I don't want to go down to the other hospital, it's too far away. So they stay here, and it's just a bit boring in my opinion. I like being...
You like chaos.
On my toes. Yeah, a little bit.
I guess you would be learning a lot.
Yeah.
Not only about your occupation, but people. Because in emergency, you're dealing with... Everything. You're hands-on with people. You're the You're the first call to action. They come into you first before going to another ward usually.
Yeah, and I think the other good thing too is that, if you don't like a patient, they're usually gone within a day in emergency. Whereas on the wards,
you could be stuck with them for weeks or months.
Exactly.
Ooh.
Exactly. Not that that's like the only reason, but one of the perks, I guess.
Mum was in the ward for a while at hospital. Most of the time, Mum was away from home for the 2 years. She was in a brain injury rehabilitation centre, which is basically aged care for disabled people, with an element of rehabilitation. do as little as possible, is what it was. Really sad. But yeah, no, Mum was in hospital for a little while, and it was an interesting experience. I used to go and see her every day. Every day I'd go and see Mum after milking. I'd be with Mum for around 2 hours or so every day while she was there for 6 weeks. I think she was there in the local hospital. And yeah, I used to get to see the hospital team working hands on and the ward work and everything. And there was a lot of routine. But it was fascinating.
Yeah.
It was different to me. It was different.
Mm.
And I made a lot of connections with the people in there, a great rapport with them. And 9 out of 10 of the nurses in there were fantastic.
Yeah.
Fantastic. There is an element, of course, in nursing where people shouldn't be doing it. Frankly, I say as a person who's not a nurse and can get away with saying things like that, there are definitely people who are nurses who should not be nurses. Some of the situations I dealt with through Mum when she had complications and had to go to hospitals, into emergencies and then into wards. Some of the stuff we had to go through was just really poor, really sad, and it was the culture.
Yeah.
It wasn't anything else other than that. They had the resources. It was the culture. It was the people involved, really only there for the money, not there for the people. Just there solely for the money. Which, a lot of people do that these days, but when you're working hands-on with people in health, in care, it doesn't sit right with me. I don't think you should be in that occupation if you don't care about people.
Simple as that.
Or that capacity to pretend to care. Categories of triage. Triage. Not triage. Triage. The categories of triage. It's funny how we go like garage, triage, parmigiana. Sometimes that G has a j sound. Don't you find that interesting? So categories of triage in emergency. What are they?
Well, do you know what they are?
No.
All right. So
Well, actually, I do. Actually, I do.
Now.
So category 1 is the most severe. And category 5 is the least severe, which is around the wrong way. So what's the go? Who designed it? Why?
Well, I don't know who designed it, unfortunately. I can find that out quickly if you like.
Not really.
But
Who are they? Find them for me.
I can tell you. So category 3 is basically someone that's had chest pains during the day, but it's not radiating anywhere. It's literally just sort of, they've just had a little bit of a pain in their chest. They're not short of breath or anything like that. If that were you, how long would you expect to be waiting there to be seen? Like at the most, is what?
Okay. When you say expect, I take into account 2 things. How long I'm meant to be waiting and how long I end up waiting.
Yeah, well, I want you to tell me how long you think that person should be waiting normally if there was nothing.
Okay, I'll give you 2 answers. I'm meant to be waiting 15 minutes to 30 minutes. I end up waiting 2 to 3 hours.
Yeah.
Am I pretty much bang on?
Pretty much. So I'll give you the actual list. So category 1, so it's an immediately life-threatening. They should be seen by a treating doctor or nurse within 2 minutes of arriving. Category 2 is imminently life-threatening. So the patient should be seen by a treating doctor or nurse within 10 minutes.
And category 3
is potentially life-threatening.
That's what we were just talking about. How long is it?
30 minutes.
So I was right. 30. They're meant to be seen within 30.
Yeah.
Is that what actually happens?
God, no. We have patients waiting for hours at our local hospital. It also depends on what's happening in the department at that time. So if every bed is full and you're not in immediate danger or your life is not immediately threatened, you'll be waiting until there is a bed.
So, in the instance of, say, being bitten by a snake, a brown snake, eastern brown,
So that would
they'd put you
be,
through like straight away.
yeah, you'd be on either the triage bed if there was no beds, or we would bring a seat in somewhere to sit you on so that we could take some bloods from you, check everything. Like, or we would be
Well, if
moving
you're
people
bitten by an
out.
eastern brown, I think you've only got half an hour to live.
Mm,
You'd
yeah.
have to act so
And if you
fast.
know that it is, like, it definitely is an Eastern brown, you need to tell the nurse straight away. You need to say, this is what I was bitten with. I'm 99% positive that this is what I was bitten with, because we can get antivenom and give it to you basically straight away. And then we have to check for like the clotting factors of your blood, what it's
That would be
doing.
horrible, wouldn't it?
Yeah,
That would be absolutely terrible.
it's a bit rough.
So, say you're category 5, which is the least.
Category 5 basically means you should be going to your GP for this while you're here.
Okay.
An
What would
earache.
be a category 5?
An earache that they've had for a day. A cough that they've had for 2 hours that has no other symptoms. And they're
And people come to hospital with these things?
Yep, all the time.
Things which really, stuff like that doesn't
That's
even
why-
merit going to a GP.
Yeah, but that's also why that these category 3s and sometimes 2s and 4s are waiting so long, because
The backlog of category 5s.
and like 4s are still kind of like, you probably could have just gone to your GP, but like, fair enough, I guess, if you've come here because you can't get in, because that's the other issue, is that no one can get into GPs animore unless it's like 2 weeks later and it's like, well, I'm sick now. So.
Well, that's it. You book for an appointment with a GP, you are waiting. Unless they, we can fit you in with this other doctor you've never been to before tomorrow.
Yeah.
It's like, I'd rather my GP, but
Yeah.
it's, I've done it where I've gone, okay, well, I'm going to go to a different person today, and it is what it is.
Exactly.
But you're right. The public system obviously can't handle the sheer amount of people who require assistance, which brings us to ramping.
Yeah.
Which is not building ramps in your home.
No.
It is.
Do you know what it is? You tell me.
Well, I guess ramping is the congestion of ambulances waiting in the bays next to the emergency department with patients within.
Or in the corridor even.
Waiting to be seen, basically.
So ramping basically happens so last week at my work, we had no beds in the hospital. We had no beds in emergency because they were full. We literally couldn't move anyone anywhere. Like, we were just bed blocked. And you literally can't do anything unless someone's getting discharged, or unless you're like, oh yeah, well, this person's fit enough to go home. You can't do anything. You literally just have to wait until someone is either moving or going down to a different hospital, things like that. And so when an ambulance comes in, they are stuck. The ambulance literally has to sit in the hallway with the patient on a stretcher, and they sit there and they wait.
Unable to assist others in the community who really need paramedics to come to their aid and accompany them to the hospital. There was a news story about that a month or two ago about that woman who rang up. She was waiting and waiting and waiting. I think she'd cancelled her ambulance. She called 000. Ambulance is on the way, taking forever. She cancelled it, went to sleep, and she died in her sleep. Is that right?
I think so, yeah. If something had happened, and yeah, the ambulance didn't come, and she passed away because no one came to help her. And she had no one that could take her.
I mean, I don't know the case, and you could critique it and say, well, why didn't somebody else take her to the hospital?
Well, yeah. Exactly.
But that aside, genuinely just looking at it as a ramping issue, that's what caused it. There were no available ambulances because we had a backlog of patients in the public system.
And then the other issue is you've got people, so you've got these ambos that are ramped, and, in smaller rural sort of settings, you might only have 2 ambulances in that area. And, you might have an extra one, but it's out in, one of the other neighboring communities that's normally meant to be situated there. Like, for us, we have one that's about 45 minutes away that stays there unless they're bringing people back and forth, but they're situated out there. And then there's, however many there is in town. And you then might have to get this crew that's out there to come and start doing the jobs in town. But then if there's something that's happened out in that half an hour, 45-minute away town, there's no one there to help them because of that. It's just crazy. I got some statistics. Would you like them?
I love some juicy stats.
So these are Queensland stats because it's what I looked up. So between 2021 and 2022, this is the financial year that I've got, in the state's top 26 hospitals, how many hours do you think ambulances spent ramped?
You mean accumulate, like all of the ambulances in Queensland?
In the top 26 hospitals of Queensland.
Right. Just every single one combined. How many hours did they spend ramped? Jeez. Oh, God. I wouldn't give me a ballpark figure. Like, give me rather, not a ballpark figure. Let me know. Give me a range that I can guess between.
More than 50,000, less than 200,000. It's a pretty big range, I know.
Is it like 100 and something thousand hours?
134,155 hours.
Gee whiz. Sitting, waiting. And people then blame the paramedics and get aggressive with paramedics.
And then we also then get blamed afterwards once they hit the bed saying, oh, well, why did you guys take so long? Why couldn't you see me earlier? And it's like, where could we put you? You literally came on the bed. As soon as this person left, we stripped it, we cleaned it and put you on it. Like we didn't even get 2 seconds to put some paperwork away. You went straight on the bed as soon as that person left. And it's nuts. Like we have so many issues with that. The government now though has just come out with, and they're trialing a new, so in Queensland, the form that we use to, I guess, give a score to a patient as to how unwell they are when we're looking after them, that can, like, it fluctuates. It's like, you know, how fast they're breathing, how fast their heart rate is, things like that. It gives you like a number. So it's either 0 if it's in like normal ranges, or if it's outside the normal ranges, you get like a 1 or a 2 or a 4, or an emergency call, things like that. The Queensland government are now announcing one of those similar forms to the paramedics for when they're ramped. So the paramedics actually have to start filling them out. And if the patient is scoring...
That's great, isn't it?
It is.
No, is it? No, I mean, I'm saying that sarcastically because the paramedics now got more paperwork to do while they're trying to deal with what's going on inside or outside of their ambulance.
Yeah, but listen, the reason that they're doing it is because a lot of ambulances are refusing to put a patient in the waiting room. So when they're on the ramp, the paramedics don't do anything on the ramp. They keep them hooked up to the monitor, but they're not writing these vital signs down anywhere. Like they're technically in the hospital's care once they're on the ramp. So the paramedics are just standing there waiting.
Yeah,
not that they're not doing anything.
So how does this paperwork fix that?
So this paperwork, if they're scoring a 0 and they're not clinically frail, like they can mobilize, they are allowed to go in the waiting room rather than being on the stretcher with the ambulance. So before this...
So this will... I see this actually as an issue. Okay. Because you got your instead of these people waiting in the ambulance or in the corridor, they're being moved to another room. And so these paramedics are then going out and retrieving more people. And so you're actually going to have more patients coming in more and faster because the entry system is more efficient. That's the entry system. The system to get on the waiting list is more efficient. You get to wait sooner. But it doesn't necessarily mean you get to go through sooner.
No.
And so I actually see that as an issue because you're going to have a waiting room full of people who were from the ramping. And then the ramping is going to be even longer as well because the waiting room will end up being full, potentially. And you're going to have paramedics there having to wait with other people who are higher risk eventually.
Yeah, true. But then it also, it's like got pros and cons like anything does. the
The
paramedics.
pro is that you're clearing the corridor out for 2 seconds and putting them in the waiting room.
Yeah, but the
But they're still gonna.
the paramedics can also go and get those people that are sick, because if they're already loading a patient up into the stretcher and they get like, I don't know, a Cat 3 call or whatever, they're going to take the patient to hospital first and then go to the Cat 3 call.
Mm.
They're not just going to unload the
I
patient
guess
and put them back on the floor.
the pro of it is that somebody who is not that unwell can go to the waiting room, and the ambulance, the paramedics, can then go and get somebody who is
more clinically
critical.
unwell. Yeah.
I guess that's good.
It's
but
got
also,
pros and cons.
yeah,
and it might not work.
You
like
are
this.
creating a physical waiting list in that hospital, which is a lot longer.
But it's got
because
pros and
more
cons.
people
And it
are
could,
there
like
waiting.
it could work, it could not. It could make ramping worse. We won't know until the trial is up. I think they trial it for like a year or two and then make a decision, basically.
You know what would fix ramping? A greater
funding to the hospitals and making more beds.
Creating a greater capacity. Because funding doesn't always necessarily mean better service.
No.
I think they just need a investment into the system to create a greater capacity for health care.
And our hospital hasn't changed. The one that I work at hasn't changed at all. Like, obviously it has from like the 80s and everything, but in the last, like, since COVID, the amount of people that have moved to our area versus the amount of like the hospital is insane. I don't know the statistics, but I just know that our hospital has grown. I mean, sorry, not our hospital, our region has grown significantly, but there's been no change to the hospital system. Like, there's no extra beds, there's no nothing to be able to put these people that have moved up and become unwell. It's just a bit rough.
Nursing culture. Do you know the average age of nurses?
I do.
Do you have that juicy stat on board?
I have that stat. It's different in every state. So
the average age of nurses are...
So within all of Australia, it's roughly, for registered nurses, it's roughly 42 and a half years old.
That's not old. Which is the oldest state?
The oldest state is...
For average.
Tasmania.
What's the average?
43.5.
Oh.
Do you know how many registered nurses there are in Australia?
Give me
your best
I'm
guess.
going to say 27,000.
Really?
Am I wrong?
309,851.
Oof. That was
There's 25,557 midwives in Australia. This is the 2022 stats. By the way,
it'd be close enough. Far out. I was way off. There are that many nurses. Seriously? That's a lot of nurses. That's way more than I thought. That's fantastic. Has that number grown?
I couldn't tell you.
Okay, that's really interesting. That's really interesting. We'll have to look at the statistics. I love them so much closer, and we can find out whether that's grown or not, because that's way more than I would have thought. I mean, so each capital city has probably got around 27,000.
Probably. Well, when you think about it, you know, you've got in most, well, at least in the rural settings and most hospitals, often the bigger hospitals have different shift times, but most of them have at least 3 people, like 3 shifts a day to count for. So 3 shifts plus, say, you know, in our department, there's probably, I think there's 11 or 12 people on a shift, except for night shifts. Night shifts, there's 8. So when you think about that, you know, like that's at least 30 people a day that they need. And most nurses, as I said, only work sort of 0.6, 0.7 as a usual, and then they pick up extras. Like, I'm contracted 0.7, but I usually work 0.8, sometimes 0.9. Depends on how I'm feeling.
feel like this is a topic we'll have to touch on again because
Mm,
there is so
there's so
much.
much. There's so
But
much.
today, I think we've definitely gotten an insight for those of us who are not nurses, a massive insight into how it operates.
Mm.
Yeah, it's been interesting to learn a few new things today
See?
about
New
your
stuff that you haven't
life.
even known.
Yeah, I mean, and for everybody else listening who isn't a nurse or doesn't have anybody in their life who's a nurse, it's interesting to see the other side of it.
And
Understand.
especially for those that haven't even had an interaction with healthcare. You know, like you've never been sick enough to have to go to hospital or anything. Now you know what it's like.
So I want to know, what grinds your gears?
The thing that grinds my gears. This is health related, by the way. We've kept it on brand for today's podcast. The thing that grinds my gears is when you're halfway through treating a patient, or you know they've been in your cubicle for 30 minutes and you've given them some pain meds and maybe some water and a sandwich, and then they go, I think I'm just going to go home now. Sorry, what?
So we're talking about category 5s here.
Even
Or
sometimes category
4s.
3s, my
Oh,
God,
yeah.
you honestly.
And I guess you can't stop them.
No.
Can you stop anybody from going home?
Yes. So only if they are on what we call an EEA.
Which stands for eating extraordinary apples.
I don't know the middle one. It's like an extended something authority.
Okay.
So, and then there's also, it's like a treatment authority.
So basically, if they're in a fairly critical condition, / not stable, / incredibly contagious, or something like that,
they
you
can
have
leave.
to.
No.
They can leave.
It's usually the only people that we can leave are either people
who won't.
That we can't let leave,
Yeah.
sorry, are people who have been brought in by the police and are under a recommendation for assessment. So either they're mentally unwell or they are, you know, from the watch house or something. You can't let any of them leave. So a treatment act.
Probably for the best.
Yeah, probably for the best. You have 6 hours for
a bank robber. I'm going to go
EEA.
now. Oh, okay, bye.
Well, the police stay with you in that case, but also security stay with patients who are on an EEA.
Okay.
So they can't go. But anyone else, if they really want to discharge, they can discharge. But there's a form that they have to sign, especially if they're really unwell. So they're basically they're doing a Dharma, which is discharging against medical advice. That's what we call it. Okay. Not like Jeffrey Dahmer, just Dharma. Or just AMA. So against medical advice. Because it looks like that's what you were thinking about when you looked at me. What really grinds your gears?
The waiting time at the hospital. When I go to the hospital, I expect to be seen immediately.
Do you?
Well, I mean, now I've had an insight into everything. I understand the other side of the coin, right? But when it does irritate me a bit when I've not had to wait myself, but I've had to wait with people who I've known have had they're more serious than some of the other cases you may see. And you're going, why are we still waiting? I understand now, obviously, but you can understand the mindset of people who don't understand how the hospital's working. They're going, why am I waiting? Why am I waiting? And I can empathise with that. Sometimes you're there going, why am I waiting? So that does grind my gears a lot, I guess, health related. But also, I guess, what you just said too. Don't go into the hospital if you're not that ill.
Yeah, or if
don't
you're just
go to the
leave.
hospital if you think you're not that bad that you'll be halfway through being seen to. Oh, you know what? I'll go home. Yeah. Well, thanks for that. Now, a number of people who needed assistance who were critical potentially, they weren't able to get in because you've been hogging a bed for an hour or two.
Exactly.
For what? For nothing.
Yeah.
Thanks so much.
It's gotten better now too. There's a lot of things that nurses can initiate themselves now. So like simple analgesia, Panadol, Nurofen, Endone. Endone's not necessarily simple, but depending on
Since when?
Yep.
Since when? I
don't actually know since when.
Okay, because when Mum was in the system and we needed an endone, she had to be ticked off.
It's only since it's only an emergency. It's not up in the wards.
Okay.
only an emergency, and it's only if
The
they're
2 nurses have to sign off on it.
Yeah. That's still like the normal. But to prescribe it as such, a nurse can do it, but there is specific criteria that they have to meet
Okay.
before you can give it. We can also give ondansetron, it's like an anti-nausea medication, and we can do some x-rays, things like that. It's gotten a lot better. So
That was a nice
you go.
note to leave the grind my gears on.
Just trying to make it a little bit more positive.
Yeah. Well, there we go. Well, everybody, thank you for listening to us this week. I hope you've learned a bit about healthcare
I hope you've enjoyed all
from
of
our
my...
expert over here, in-house expert over here. Next episode, we are speaking politics.
Yeah.
We're going to get political. We're getting so political. And quite frankly, I love it. I love it so much. Believe me. It's so good. We're going to be speaking about politics in Australia, how the system works, and that will be with Lou O'Brien, who is a federal member of parliament and former deputy speaker. So that'll be interesting.
It will be.
Yeah, and that's coming out next Thursday. So
thanks so much for watching.
The Fools.
And listening.
The Fools.
Seldom.
Differ.
Podcast.
All right, gang. Be good or be good at it.
Toodaloo.
Bye.